Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to another episode. Today's conversation is going to stretch how we think about palliative care and who it's truly for. When we talk about access, dignity, and dying well, we don't always talk about the people who've been excluded all of their lives. People living without housing, people without consistent access to care, people who've been marginalized again and again. My guest today is Ashley Mollison. She's the project coordinator at the Institute on Aging and Lifelong Health at the University of Victoria. She's a researcher, advocate, and educator who focuses on palliative care access, social exclusion, and structural vulnerability at the end of life. She's spent years working alongside people who are dying while unhoused, in poverty, or pushed out of traditional care systems. Molly, welcome, and thank you so much for being here today.
Thank you so much for having me, Traci.
First, can you start off and just tell us a bit about yourself and what led you to this work?
Yeah, absolutely. I'm not sure how far you want me to go back. It won't be too long considering I'm only 25. No, that's a lie. But I really do situate my beginning of my entry into palliative care, I would say, in about 2009. I was doing some volunteerism, activism, and work, and paid and unpaid work in relation to the street community in Victoria, BC. Um, and in 2012, a few years later, is when I was working as a frontline worker in a harm reduction facility. And we really started to see a lot of deaths from toxic drugs. And a lot of our job actually was reviving people out of bathrooms as people that were just trying to, do the best that we could with what we had, and facing the effects of that work on our heart and our spirit and our physical bodies as well. And in 2016, actually, our government started counting the deaths but from toxic drugs, and I think now we're over 50,000 for sure, but that's definitely not counting all the people that use drugs and people, like you said, that are socially excluded and marginalized and facing the inequities in our system that mean early and unjust deaths, barriers to diagnosis, treatment, support. So in those days, I worked directly with people, witnessed a lot of injustice, but on the other hand, saw a lot about how people that were living homeless and had other barriers to kind of mainstream care were very much caring for one another in community settings, and workers that were alongside people and building these really strong relationships. So I ended up kind of being a bit burnt out from the frontline work and picked up a job at the University of Victoria, working with Dr. Kelly Stadjahar. She was starting a project looking at the end of life experiences of people that were living homeless and facing other inequities. And I didn't have a background in palliative care, but she was looking for someone who could build relationships with people and also with organizations in inner city settings. And so I got hired on to be a project coordinator. So that was my starting foray into palliative care. And really, we ended up doing a 3-year study that looked at the end of life experiences of people that were homeless, but not only their barriers to care, but really, like I say, how they did access care, who were those circles of support, what helped get people good access to care. And yeah, and so that kind of started like the last 10 years, and trying to advocate for not only better access to palliative care and systems, but also how do we build capacity, and draw on the strengths that exist in community to care for one another in these settings.
It's really interesting because you mentioned people who are homeless, who have poverty, and you're in Canada.
Hmm.
And of course, in the US, we have that same issue, but also now what we're seeing, especially with some changes that are happening
Mhm.
In our government, we're seeing a lot of people who are maybe not disadvantaged, but who are living in really rural communities where they're,
Mhm.
and so we're seeing a lot of hospitals and especially palliative care. Palliative care is seen as one of those luxuries almost. Isn't that sad to say?
Mhm.
Um, so we see a lot of problems in maybe not disadvantaged, but rural communities. And are you seeing the
Mhm.
same thing up there?
So, yes, rural and inequities in access to palliative care for people living in rural and remote areas. So, one of the things that we, as a program of research, always try to talk about is the fact that equity affects everybody, inequity affects everybody, and of course, at different levels and different magnitudes for sure. But really understanding this idea that people live in different conditions, they have access to different resources. Some are at, lower on the hierarchies that we have in society, some more privileged. And so we need systems of support that are really going to recognize the different needs that people have. So, for example, for rural and remote people, they might need transportation built into systems to enable them to get to the services, to get to appointments, to get to cancer treatments, things like that. Just as a person that's living on the street might require food, might require shelter to be able to manage treatments and things like that. So and they might need transportation to get to appointments. So it's really kind of that recognition that a one size fits all approach in our systems don't work for everybody, or they work for one segment of society. So it's really trying to build equity into every level of how we offer programs and supports and services.
Yeah, I love that you mentioned that it might take or that will affect everyone. My parents
Mhm.
are at an age where then they're on Medicare here in the United States,
Mhm.
which you have to go on. Once you hit 65, you're not. You could have private, but you also have to pay for Medicare. And so most people are on Medicare. And they've told me that many doctors won't even accept Medicare. So they're having
Mhm.
problems. And they live right outside of Chicago. So it's not like they're out, in the middle of nowhere, but they have
Mhm.
problems finding specialists and finding people who will accept their insurance, which is a
Mhm.
standard insurance for older people.
Yeah.
So,
Yeah. And the more that we can use these examples, I think, to enable people to see the need for equity everywhere,
yeah,
the more it's going to benefit those people that need it the most.
yeah. And it is
Yeah.
very systemic. It is, but that's a big push to get the government to change what it's doing, right? It's really, uh,
Hmm.
so I know that you've spent a lot of times alongside people who were facing the end of their lives in very tough circumstances. A lot
Hmm.
of times they might not have housing. And when we spoke before, it was really a very eye opening conversation to me. Now,
Hmm.
how did your perspective shift as you spent more times within these communities?
Hmm.
If you can remember back that far.
Oh, I should be able to remember considering just a few years. But the I was, I'm right in the middle of working on a PhD right now, or trying to finish my writing, and we spend a lot of time in this process thinking and reflecting on how we come to what we know and how we got there and how our life shaped our experiences. And um, I really think that, my experiences, as I shared before, in the street community and seeing people look after one another, um, that's something that was really embedded, like seeing the strengths and the power of community, I think was really embedded in me in an early
Mm,
age. And my mom actually was a community health nurse, and she always worked in First Nations communities in our country. And she and even though we're a settler family, like we're a white family, we got invited to participate in a lot of the luncheons and the activities and the ceremonies and things like that that happened in those communities. And so even though from a young age we learned a lot about, inequity and were around it and saw it, we always really saw that alongside how people care for each other and support each other outside of just nuclear family, but also in, extended family relationships, in community relationships. And so when I started university, I had this course and it was on HIV and AIDS in Africa. And I became so fascinated in AIDS movements. And I know you just did a podcast looking at like early days of AIDS activism, AIDS movements, and by people that were excluded from mainstream systems and trying to, and you were part of that as well, right? And I think so you will be able to reflect on this as well. But um, I think I was always really, from a young age, kind of attuned to the power that we have as people to fight back against systems. And I brought that a lot, and that's a lens that I bring into my work. But I think in kind of bringing that lens, I've kind of written mainstream health systems off. And it's a bias that I've kind of almost let them off the hook and said, okay, you know what, communities can look after each other. And I was reminded recently about how exhausting that is. And I think back to my own experiences of, being just like mentally, emotionally, physically just drained. And when you're trying to provide the care, but you're also fighting all the time, right? And I think those experiences are even more pronounced for people that are, more marginalized and living it, every day. So in the last few years, what I've kind of been, and I will get to answering your question, but I just want to give a little bit of this context because in the last few years, I've really been working with systems and meeting the people that are in mainstream health and social care systems, finding out how people do want to care so much and want to be part of the solution, but work in these really kind of constrained places. And and so I think my perspective has shifted, not so much from the communities that I've worked with, but turning the gaze to the system and the barriers and realizing that we actually, in addition to what people are saying and living and yelling about, and I was one of those people that was yelling and demanding for better access to care and housing and social support, we also need systems that can hear what is being said and understand what's being said. And so I almost feel like that's the next chapter in my life right now. And that's how my perspective has shifted over the years, I think, to really understand the roles that, dominant mainstream systems have in seeking to understand, walking alongside, reducing barriers, because that's active work and that's hard work and it needs to be done.
Yeah, I love how you mentioned that listening, because I think that people who aren't exposed to different communities, that they just believe that if we expand access, then everything's going to be okay, especially access to palliative care. But I know that your work tells a different story. And when I was talking to you before, it was so evident that it's just not about actual access. Now, what are we missing when we assume a solution is, simply to offer more palliative care? And I think when I'm thinking about this, you talk to me about the communities and how they take care of each other and how we, in the mainstream, what we assume as an example, what family is. So that's like one example that really stayed with me when I spoke with you last time.
Yeah, definitely. And so the more that, we do this work, the more we see that the problem isn't in the alternative lifestyles that people live or the behaviors or the different ways of being or whatever. The problem is in the assumptions that we actually hold in our systems, right? And so the assumption that you just brought up, that so people might be accessing care from a diversity of people, friends, neighbors, they might be estranged from their family members. They might have trusted workers that are providing them support, such as in the shelters or in the housing. Um, But the problem is that inevitably people get sick enough that they need to access care from mainstream health palliative care systems. And in those systems, we default to biological family, for example, or biological or legally related family. And so all those kinds of naturally forming networks of support get excluded from care, right? And so and that has really kind of delirious like consequences for people and those that are left behind. So that's just one example, but I think it is really like the biases that exist in our system that, for example, people will have homes where quote unquote home care can go and provide them palliative care, or that they'll have finances to take care of those extra out of pocket expenses that come with end of life. You need specialized diet, so you need to blend your food, or okay, well, you need a blender, you need a place to be able to prepare food. Sometimes when people are living in congregate settings like shelters, they don't have their own private kitchens or bathrooms or, that kind of thing. So having money, having home, having food access, having family support is a big one, right? Because we just assume that family is going to step in to take care of so much of that, the work that happens at end of life, and that's required at end of life, and that's not the case for a lot of people that at least that we've seen in our studies. I won't say that family's not around, because the other interesting thing that often happens is that end of life provides an opportunity for reconnection to happen. And sometimes people want to reconnect with family, or family want to reconnect with them, or maybe the medical record still lists the person as the next of kin, and health systems bring the family in. So it's just more complex than we understand, and that our legislation and our policies recognize. It tends to be more complex on the ground.
Yeah. Now I know with people who are experiencing the homelessness, and deep social stigma, there isn't often a place, as you said, where death is allowed, and some of that is what you just mentioned. And I read a few of your articles, and you've co-authored, and the phrase "you can't die here" appears in a few of them, from both a practical and emotional perspective. What does that message do to not only the person who's dying, but those that are trying to take care of them? I mean, it is,
Yeah,
I,
well, I'm very impressed that you read a couple of the
oh,
articles. Thank
Google
you for
Scholar
doing that.
is amazing. I looked you up. Oh my goodness, you're like prolific already, and you're so young. You're all
Oh my
over.
God, I've done so much in 5 years.
Yeah, yeah.
Um,
It's amazing.
uh,
I'm really impressed, and I thank you for everything that you're doing and have done.
aw, I appreciate that. And I always feel so humbled when people say that they read the things that we write, because I always think about the impact being the work we're doing out there. But it
Yeah.
is really cool to think about all those hours spent writing, and that it has an impact. So, and thank you for inviting me again today. I feel very special. So thanks again. Yeah, no, so You Can't Die Here is often the unsaid,
Yep.
not the said. Uh, so
Yep.
um, the bigger picture, we were talking about assumptions, and we were talking about how we build our systems of support. And the homeless service setting hasn't traditionally been set up to provide kind of health care. It's been set up to provide care to a relatively independent homeless person who's not connected to family and friends, or living in a family unit, or living with a partner or a pet. So it's quite, yeah, I'd say focused on independence as opposed to interdependence. Um, so this is changing over the last, decade or so. There's definitely been a lot more moves to integrate healthcare into homeless services, and that is simply a recognition of there's many people that have disabilities and chronic health conditions that can't afford to live in an increasingly expensive world who fall into homelessness. We have so many more seniors that are on the streets, and that's one of the fastest growing homeless populations. And those that are not able to afford um, housing on limited pensions, like fixed incomes. So we have, low disability rates. We have low income assistance rates. We have that are not keeping up with the standard of or the cost of living, and then low pension as well. So people do what they can to live with their families, sleep on couches, and inevitably, there's a subsect of those folks that can't get that support from family or can't move into an institution and go to the street. So and then we see kind of among people who have been homeless for a really long time, this phenomena of accelerated aging. So people that are, say, like 50 are more, physically and cognitively like 70. And that's just, the being out in the conditions as, being out in the weather, exposed to violence, all the things, right? And so um, so even though I think there is more integration of homelessness and health services, it tends to be that when people get to that point of needing more like health support, so they're like not moving around as much, not able to get out of their rooms and downstairs for food. Oftentimes people have to access their medications at front desks, things like that. So once they get to that point kind of where they're not able to move out of their room a lot, um, they become beyond kind of the level of care of those facilities. So that kind of "you can't die here" is really just this recognition that the places that are homes to people that are homeless, like shelters and transitional housing and even tents, things like that. People get to that point where they either get evicted from those places or are moved to like a higher level of care. So that would be the just practically like what tends to happen. There's also kind of a phenomena of people not being able to be honest and vulnerable about their own health conditions, and the support that they do need. And barriers to mainstream kind of home care going into the settings where people are. So not being able to offer care in tents, not being able to offer care in shelters and congregate settings. So yeah, there's just a lot. It's kind of complex, but it's a good question, because it really does bring to light the discrimination I think that people face if you don't have a home and don't have money.
Yeah.
You're not able to die at home, which is the kind of standard of palliative care that we measure, good palliative care
Yeah. And you
against.
you talk about social death too. How does all of that tie into social death?
Oh
You've
gosh,
written
yeah.
about, yeah.
Social death is a big one, but I mean, social death refers to people not being treated as fully human, right,
Yep.
in life.
Yep.
And it's easy to just kind of pick up a newspaper or read the news and see evidence of,
Oh yeah.
metaphors that people are
Yeah.
being used to describe.
Yeah, you don't have to talk about that with me. Especially, it is really very common, and that's unfortunate.
Yeah, yeah, referring to people as like zombies
Yep.
on the street or something like the Walking Dead and things like that. So yeah, that dehumanizing language
Yes.
that we use to describe people. And I mentioned before, like obviously the huge risk of death, overdoses and things like that. But how does that play out in, palliative care is actually a hopeful message because in our studies, actually, people have said that the best care that they've ever gotten is palliative care.
Mm.
And so they live a lifetime of not getting good care, of not being treated as fully human. And then they get access to care because they all of a sudden get identified as dying, and or living with, a serious illness. And they get providers that understand what holistic care is. They understand what mental, spiritual, emotional, physical care. All of a sudden, instead of being treated as an addict, they're treated as somebody that has pain, um, which they were probably self-medicating for many, many years prior to getting identified as having pain and symptom needs. And they get asked what they want instead of told what to do. So palliative approach to care actually is what we advocate as just care in the face of injustice. Yeah.
Yeah. Now, in some of your work, you describe people holding on to life because they don't want to die on the street. Um, what what would that look like for us to change that as a community, to show up for them? What do we need to do to help?
So we have a few different models of care that are becoming popular in Canada, or at least known about. And I'm not sure if you have them in the States as well, but so we have these like inner city kind of mobile palliative care teams, and they consist of physicians, nurses, outreach workers, some have peer workers as well. And they move between systems. So they're able to go into community settings, build relationships with people, um, do all of the asking, what is it, what's important to you? What are your priorities in your own care? What does care look like? Who do you want surrounding you when you, as you continue to live with your illness. And these are really promising. They've had really, really good outcomes in terms of being able to like provide that continuity of care from home, shelter, tent, wherever that is, to hospice or to the hospital, or supporting people as much as they can to age and die in place. But then I think in like mainstream systems, we need to work with people that are most affected to build services and programs. I think that is also equity. Equity is like not just what we do, but how we do it. And I think how we do this better is to engage with people to see like not just on that individual level of service provision, but like how are we like who's included in decision making about how this service operates, where does it go, how, like all those kind of like program development questions, but like how do we better engage with not just people who have privilege, but those who are also, marginalized. So I think that's important. Yeah.
Yeah, I think that there's such an assumption, as we talked about before, that we know best. We're the experts. We know best. We know what, and we don't. Everyone is so different. And so it's that listening that you talked about at the beginning that we need to do.
Yeah, listening and doing something with what you hear, I think is important as well, because I think there's like that listening that happens, but then where are the pathways to change like operations? Like how do we like equity is practical. It's like how do we actually get this to this person? How do we, if we want to give more to some people, we might need to redistribute resources and think about the ways that we're, if people need less, maybe we offer less, and then maybe we give more to people that need more. It's hard decision making.
Yeah.
But like equity really is like work. It's action.
Yes. Yes.
Not just nice words.
Definitely. Now, I know before you spoke about when you were first coming, or when you were volunteering, and when you first got involved in this, and how this was difficult on you just emotionally and those around you, the caretakers, or sorry, the caregivers who were doing this work or helping. How do you keep going? How can we support people who are doing this work?
Yeah, I love that question. I think that so I think a lot of things about this, but I think that seeing, so a better recognition that the frontline work, when we're talking about people that are walking alongside people every day, um, so many people don't see themselves as caregivers. Obviously, they see themselves as paid service providers. But they speak about a care and a relationship and even a love for the
Mhm.
people that they serve.
Oh, yeah.
Um, that is not describable. I find like often people are operating from an imperative, which of course you need to be really critical of your own kind of, imperative to care. But my experience has been that people are offering a type of care and their clients are seeing them as more than workers sometimes, like they're maybe referring them, oh, she's like an older sister to me. She's like a mom. She, you know, and so these strong relationships are developing. And so there's a lack of recognition that that is happening, and then a lack of kind of guidance for how to understand these relationships, and then a lack of kind of policy and support um, for attending, to this really hard work. I think when I first left kind of the frontline work and started working in palliative care, I can remember the project, the PI on the project. She's like the one who gets all the funding, Kelly Stadjahar, and leads our program of research, and she has the vision. And she really, said to me, I was really angry. I was, raging at systems at all times. And she said to me, you're grieving.
Mhm.
And that was the first time that it had been framed that way to me. I had heard about burnout. I'd heard about compassion fatigue. I'd heard about vicarious trauma. Um, and what we hear from workers that we work alongside is that you can be punished for that kind of care, right? Like you're punished for having those kinds of relationships, but they're human. Like being a human is also what makes you a good worker
Yes.
in these contexts, right? So I think we don't recognize or have frameworks or supportive policies to understand these kinds of roles. And then I think we need better grief support because we have one-to-one counseling, we have debriefing. But what workers say helps is, collective, ritual, being with people who understand what you're going through, not necessarily talking to a counselor who's going to kind of say, you know, oh, like give you that look of concern when you start talking about your everyday work environment, right? It's better to be around people that kind of understand so you don't have to kind of explain everything, right? And so there's lots of different, things we can talk about in terms of grief, but the other thing and the big thing that we found in our research is that when workers get included in the care, so they get seen, recognized, and they become part of asking a person what matters to them and being part of filling those wishes in life and death. So somebody says to you, what's really important is that this baseball that, I got from this game goes to my son who I haven't talked to in 10 years. And that worker can connect that after the death of that person. That is what helps grief. So it's not even about kind of attending to their grief. It's actually better inclusion in care, better opportunities to get better care for their clients, which in turn supports the caregiver, which we know, right? We know that when caregivers see that the people that they love are getting good care, it actually, helps them as well. So I'd say that like that's a big thing that I'm not hearing a lot, which is had and what a lot of our work focuses on, which is integrating palliative approaches to care in the places where people are living and dying, including people's natural networks of support in that, because that's the meaning that you take with you and reflect on later to say, I did something. There was so much injustice, but I did something.
Yeah. I love that you mentioned that love and that caring
Mm-hmm.
that the caregivers, professional caregivers, um,
Mm-hmm.
that they provide and that they give because we're human. And I know
Mm-hmm.
that when I first started as an end of life doula, there was always this question of boundaries.
Right. I
Am
forgot
I
to say
giving,
boundaries, but that's the other thing we talk a lot about.
yeah, am I giving too much? Am I taught, yeah, am I am I oversharing? That's it. Because, you have this notion in your mind that you should be like a therapist, right? No sharing, how does that feel? How do you feel about, but that's not reality. These people are sick. They're in pain. Like the people I work with are sick. They're in pain. They're dying. And there are no conversations that are off limits at that point. There are no bullshit conversations that are going to happen.
Just gonna say no bullshit and ask you if I could say that on your
I've said it. There are no bullshit conversations that happen in my work, and there's no time for it. And so as end of life doulas, where I remember when I first got into this, and I was asking more experienced doulas, is this okay? Am I oversharing? And they're like, no, that's exactly what you should be doing. You're connecting with people, and it can't be one way. It can't be one-sided. People want human connection, especially when you're so vulnerable. It's okay. I mean, I'm not telling them all my problems or anything like that. That's not, but like as an example, they know I'm married. They know, they know things about me, and they know things, and I use examples from my life, and they know about my family, and those are things that you usually wouldn't talk about, right? That you're trained not to talk about. So that connection that you are talking about, and it does leave caregivers open a little bit more. We have to be more vulnerable, and so we have to. I love that you recognize that and have mentioned it.
Yeah, it's like we require people to give of themselves, because that is what outreach and engagement and relationship, we talk a lot about relationship building and how important that is. But relationship building isn't a one-way street, right? Like that impacts us just as much as it impacts that person in front of you in any relationship, right? And so I think it's and as you were saying, you share this, but you don't share this. And so there's a lot of thought that goes into boundaries. It's not like because you're an open person, you're throwing out your boundaries. It's even more complex, but we don't have a lot because you can't be open about that connection and relationship all the time. We don't have those opportunities to have these like nuanced, complex conversations about boundaries, right? And that would really serve people, I think.
I think it comes down to, for me at least, being authentic.
Yeah.
And I think that in mainstream, I come from corporate America, you really can't be very authentic. Yeah. And so it was learning that and learning where what to give. So it was an amazing experience, an amazing process to learn.
Yeah, I agree.
So let's talk about hospice, palliative care. What do you wish that people in mainstream hospice, palliative care, what do you wish they understood about the realities of working within these communities? I know we mentioned some of them just now, but are there any more that stand out to you?
Something I haven't mentioned yet. What I would like to say is that homeless people are in a different species. More and more, it's people falling through the cracks that were literally our neighbors and now are, on the streets in precarious housing situations. There's so many more people that are behind closed doors that may be able to pay their rent or their mortgage, but can't afford to have food in the fridge and are at really precarious places. So we have a lot to do to, prevent homelessness by, getting to know our neighbors and looking after each other. I think that should be seen as homelessness prevention. And then just in terms of I think my big message these days, just because I am focusing on caregiving in context of homelessness, is just that the way that we understand dominantly caregiving doesn't fit the reality of many people, not just who are homeless, but we're really seeing like families living further apart, people choosing not to have children, we're going to need different models that don't assume that the eldest daughter is going to do all of the caregiving.
Yeah.
We actually, like, beyond just expanding towards friends and extended family and community members, we need to really disrupt where we see those assumptions in our practice and our policies.
Yeah, it's interesting that you mentioned that. I've talked to people in our communities living in the Bay Area. We're really fortunate that we have uh, pockets of communities. We have the Asian communities, and we have the Indian communities, and usually, you have the family. They live in extended families, so you have generations living in a household. And so there's always people to take care of. The family takes care of one another. But now kids are moving out of the area. They're moving away from home. And so there's this lack of care that is starting to happen. And to see these communities navigate that is really interesting. And that's something we all need to be concerned about. We need to work with these communities.
Yeah. Yeah. And learn, right, from communities that are already doing it. Like, they have a lot to teach us about how, like, and when I say us, like white Western society, right? Like, it is very focused on nuclear family. And it's not going that well. Like, it's really not going that well for those caregivers, although there are lots of benefits, of course, as you say, for caregiving. But it's putting a lot on just a few people.
Yeah, it is. And I tell people that I work with, you could either be a son or daughter or husband or wife or a caregiver. You can't be both. And that's why you need help. And of course, for people who could afford it, they can afford to, to bring in help, to bring in people who are going to help them. And, but most people can't afford that.
Yeah.
And especially in our system where nothing is free and you have to buy insurance and we don't have universal health care. I remember my parents got, we have something called long-term care. And it's this ultra expensive type of insurance that pays for this when you really get sick and you're older and you need that extra care. It will pay for that. It's a type, as I said, it's a type of insurance. And I remember my parents, and I'd never heard of it. Most people haven't heard of it. I remember my parents being so proud when they purchased it, and they told us, Traci, you don't have to worry. You're not going to have to change our diapers. We purchased, those are the exact words that they used. But isn't that, amazing that that's just not a given, that that's not something as a community we have thought about. And there's so many reasons for that, right? We don't think we don't like to talk about death or getting sick. So we don't, but isn't it amazing that we don't talk about that, which is just that we should be?
Yeah. I mean, I've had many conversations with my dad where he says the exact same thing. And I say, but like, I'm here to change your diapers. And it's very awkward. It's a very awkward conversation. But it does bring to light all the reasons why, we just need to really, like, think and plan and be having these kind of open and honest conversations about what the future looks like. Because I think a lot of people, as you know, plan for kind of death and their estate and where they want their belongings to go, but we think we're just going to drop dead. We don't think about that time leading up where we're slowly declining. Hopefully we're not, facing sudden death, but or maybe that's better. We could debate that, but I think, that kind of, we don't think about the decline and what kinds of supports we might need in those places. And back to kind of our topic around homelessness, we find too that when people have survived so much, they don't expect to kind of get to old age, and they do expect sudden death. And there's all sorts of, reasons why people don't even have time to be planning and thinking about the future and things like that too, right? And there's a phenomena that a lot of people that have done research on advanced care planning and goals of care in homeless populations have found that people always tend to want aggressive treatment. So they don't want to sign do not resuscitate or comfort care, which can be a barrier to getting into palliative care services, right? Because they don't want to let the system off the hook. They don't want to say, like, because they have faced that discrimination, racism, stigma in systems, they don't want to sign a paper that says the system won't provide that care, right? So one of the things that we always are so, like, the message we're always trying to get out is that palliative care is not removal of care. Palliative care is more care.
Yeah.
And actually, it's better care a lot of times, right? And it's more holistic care than what people have gotten in their whole life. Yeah.
Yeah. To me, there's palliative care, which is, but that doesn't mean you're in hospice. You could get palliative care and not be in hospice. There are two things. Yes, you receive palliative care when you're on hospice, but they're two very different stages, or can be.
Yeah, absolutely. And we say palliative approach to care to kind of recognize that earlier upstream approach that really attends to, holistic needs, living with, they say at diagnosis, but you could probably say for people in this community who we know homelessness itself is a life-limiting condition, racism is a life-limiting condition. Like, we know it cuts your life expectancy. We know people experience, all these barriers that anybody could probably benefit from a palliative approach to care, right?
Yeah. Well, Ashley, I'd like to thank you so much for being on the show today. And before we wrap up, how can people learn more about your work or get in touch with you if they'd like to connect?
Yeah, so we have a website. You can go to palliativeapproaches.uvic.ca. Maybe there's a way I can share that with you.
I will take and post it on the description so people will be able to get to you.
And we have a newsletter you can join to kind of stay up to date on our activities.
Very nice. Thank you. Listeners, today's conversation is a powerful reminder that palliative care isn't just a service. It's a reflection of our values. And if we want that care to be truly equitable, we have to ask harder questions. Who is this care for? Who is being left out? And what are we going to do about it? If you work in healthcare, revisit your assumptions. If you're part of a caregiving community, expand who you see as family. If you're someone who simply cares about the kind of world we're building, then speak up. Learn, share this episode. Let it start a conversation in your clinic, your classroom, or your home. Equity in palliative care isn't optional, it's urgent. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comfort and Closure, wishing you peace and comfort in your journey. Until next time, take care.